Hello everybody, welcome to Doc Talk with myself, Adam Exley, Program Medical Director, and
Trevor Sher, Clinical Educator with the Northwest Region Pre-Hospital Care Program.
Perfect, and we are going to be talking about ALS-PCS version 5.0, going over a quick review of the updates and changes that have occurred in 5.0. The objectives of this talk are going to be to review the changes so that paramedics are able to understand the directive changes and will understand some of the rationale around some of the changes and implement the changes appropriately during your clinical care, which is really the most important part. So not all of the changes we're going to go into 100% of the details. Some of that will be followed up with both in-person education as well as further online education, which is specific to some of the medical directives we're going to be quickly going through today.
Excellent. Thanks, Dr. Exley. So the first big medical directive with some minor changes is the medical cardiac arrest. Now there's slight language changes around reversible causes, but most importantly the age has changed to greater than or equal to 24 hours, and that's just in line with the newborn medical directive, which is formerly known as the neonatal resuscitation directive. But more importantly, there will be no more maximum number of shocks delivered.
Yeah, and that was really, from paramedic feedback in creating these new directives, as well as an understanding that patching to base hospital physicians is both a hindrance sometimes in delivering appropriate care. So now there are no longer a maximum number of doses. Deliver care as to the standard with no need to patch.
Excellent. Some slight changes for the TOR criteria. Again, the age has changed to greater than or equal to 16 years of age, and again, that was from the feedback to make sure things are consistent and then there's no mistakes or mishaps with age criteria between the directives. And lastly is the 20 minutes resuscitation.
Yeah, that's probably the most significant change to the medical cardiac arrest directive, is the change away from number of rhythm interpretations or doses of medication given to a time-based resuscitation, and that is really in keeping with the most up-to-date literature around the point of futility in resuscitation. The old termination of resuscitation criteria was based on literature done by Dr. Richard Verbeek out of Sunnybrook, and that was really prior to the intervention of a number of different treatments that have come along since that literature was initially done. More recent updated literature around resuscitation and termination of resuscitation has given us this new point of 20 minutes of resuscitation. Now, I think the most important thing for paramedics to remember and understand is that 20 minutes of resuscitation, there are certain situations where that 20 minutes of resuscitation may not be appropriate. And that is outlined within the clinical consideration criteria around some situations where resuscitation might be futile. And in those situations, paramedics are encouraged and expected to patch before that 20 minutes for consideration of an early TOR in consultation with your base hospital physician.
Good. Yeah, we'll go into some of those clinical considerations a bit more detail here shortly. So continuing with the directive changes, some slight changes for the ACPs regarding the lidocaine and amio. Both of them tie in that 24-hour age gap, but there are some changes for the lidocaine dosage, changing from 3 down to 1.5. Any rationale behind those changes?
Yeah, again, that's just updating with the AHA guidelines around efficacy of medications and most recent literature around medication dosing and efficacy.
Good. And lastly, just the epinephrine slight minimum dosage change, again to encompass that newborn directive. So Dr. Exley, we'll take the opportunity here maybe to dive in a little bit more about the clinical considerations for the details that's in the directive for the mandatory patch point for the TOR.
Yeah, so this is just around that whole idea that there are certain situations where paramedics use their clinical knowledge and skills, and they know that 20 minutes of resuscitation is likely futile in that patient. And that's, let's use an example of an elderly patient who had an unwitnessed cardiac arrest, was found in their bedroom or bathroom by their partner after several hours of last being seen normal. That situation, I think we can all probably agree, 20 minutes of resuscitation may not be appropriate in that specific situation. But that information is outlined pretty clearly with a number of different situations. And I will say that the base hospital physician, when you're having that consultation, they may not always grant an early tour, but it certainly is an option for paramedics to utilize that patch point to have that conversation before the 20-minute period. And really this is empowering paramedics to use their knowledge, skills, and abilities of what is going on in this specific situation, and feel confident that when you're getting a tour now at that 20-minute mark, that point of futility has been met, and that we are giving appropriate termination of resuscitations and not leaving the possibility that we might be leaving a patient with an opportunity to get ROSC in the field.
Good, well said. Yeah, I think we can move into the trauma arrest now. Again, some slight changes to the age there, but we'll talk about some more language changes about into the core conditions as well as the contraindications there.
Yeah, so the core conditions and contraindications have been updated with verbiage that is consistent with the field trauma triage guidelines, which is a document in the BLS standards, and it just really aligns that verbiage, whereas before there may have been some contradictions between the ALS and that FTT guideline. So it really looks at signs of life at any time since fully extracted, or a rhythm of PEA, and then the 30-minute time to hospital is still there as per, but it's really that signs of life at any point. And I will say that it's any of signs of motion, so you don't need all of the signs of life, you need any of the signs of life, which is an important consideration.
So some of those signs of life include, but again not limited to, so any specific movement they may have, respiratory effort, organized electrical activity, some respiratory pattern, or reactive pupils. So like you said, any, not just one of them.
Yeah.
So that trauma arrest directive has also included something for the ACP. What was that change?
Yeah, so the changes now within the trauma cardiac arrest directive, the needle thoracostomy is included in that directive, and that is really just to highlight the importance of that procedure in trauma cardiac arrest and that etiology. So paramedics, ACP paramedics should really be thinking about doing a needle thoracostomy in all trauma cardiac arrest patients, and I will note that there is no need to patch for that needle thoracostomy, but we will also be getting to that a little bit later on in the presentation.
Good, some excellent changes for patient advocacy there. The next one is the newborn resuscitation. As I said before, was formerly named neonatal resuscitation. So outside of some specific details on when to do PPV and CPR, it does to go into some great detail about gestation and gestational age. Any comments on that?
Yeah, and again, this is just looking at the evidence around how good healthcare providers, and this is including nurses, physicians, respiratory therapists, paramedics, at how good we are at determining gestation when we don't have any information from mom or when conception occurred, and the overwhelming literature would say that we're not very good at determining gestational age, and certain types of physical landmarks may not be reliable in all births depending on gestation. So really this is, unless you have reliable information, the error should be on resuscitation and rapid transport to hospital. If you have clear information on gestational age and they are less than that 20-week gestation, then at that point resuscitation would be considered futile, and that's a situation where you don't necessarily need to transport. But again, when in doubt, rapid transport to the hospital or consideration to begin resuscitation and consult with your base hospital physician.
Fair enough. All right, so the next two directives we'll jump into the bronchoconstriction and croup, and they have a major addition to them, including the medication dexamethasone.
Yeah, so dexamethasone is an interesting medication from a pre-hospital care perspective. Great addition to both the bronchoconstriction and croup medical directives. The importance for paramedics to understand is that dexamethasone isn't like epinephrine or salbutamol. It doesn't provide immediate clinical benefit. So the benefit for patients to getting dexamethasone in both the bronchoconstriction and croup medical directives is that it's going to provide benefit to that patient hours down the line, not in minutes with the pre-hospital care. So what you're doing in that situation is you're giving patients a decreased chance of admission to the hospital, a decreased time and observation in the emergency room by getting that medication on sooner, which is a great outcome for that patient. So paramedics are now have the ability, or will have the ability, to impact that patient's care in the hospital and prevent, hopefully preventing admissions or long stays in our emergency department, which is always nice because nobody likes sitting in our emergency departments any longer than they should. The other thing to remember about anytime you're giving steroids like dexamethasone is that you need to be aware of current doses of steroids. So specific to bronchoconstriction, patients with asthma or potentially COPD may be on long-term doses of steroids, and that's an important contraindication to think about and ask questions around. Specific to croup, if a patient has already been in hospital and received a dose of dexamethasone for croup within the last 48 hours, there's absolutely no clinical benefit to receiving a second dose of dexamethasone. So specific to the croup medical directive, if they've received dexamethasone within 48 hours, there's no reason to give a second dose.
Gotcha. So some other slight changes to the croup is just the age. Then that was just the focus on recent literature that most patients 6 months to 8 years are susceptible to croup, as well as a slight change in the epinephrine medication. Again, just limiting it to just 2 variables on when that would be indicated rather than multiple steps, again, to minimize any human error that may occur for that.
Yeah, a lot of these dosing changes that you're seeing in version 5.0 and have previously been released are really secondary to some of the great work that the paramedic reps are doing on the MAC and on the committees at the provincial level, giving feedback around treatment algorithms and dosing errors that sometimes occur. So.
Good. The next medical directive will be introduction of a new medication, but before we get to that, the emergency childbirth directive has some changes where those emergency childbirth situations have basically been restructured to have its own directive rather than its flowchart or algorithm it was before. So it's more of a readability thing. But like I said before, there's a new medication, oxytocin.
Yeah, so oxytocin, very excited to have this addition to the emergency childbirth. Oxytocin is a medication that has been around for a really long time and utilized in obstetrical care in hospitals and pre-hospitally through midwives. But it's a medication that is very useful in postpartum hemorrhage, induces uterine contractions that can be very beneficial to stopping postpartum hemorrhage and treating it. Is super easily dosed through IM administration. There are a couple specific contraindications that you need to be aware of that are outlined in the medical directive. The one that I'm going to specifically talk on right now is just around the contraindication with regards to eclampsia. So eclampsia is a medical condition that causes blood pressure issues and seizure issues in pregnant women. The reason why oxytocin has a contraindication when women have eclampsia is that oxytocin can theoretically reduce a patient's seizure threshold and induce seizures. So if a patient's already at risk of getting seizures from other medical condition, notably eclampsia, we don't want to raise that potential. The other issue with oxytocin and eclampsia is you can get, as I stated in eclampsia, big blood pressure changes, and oxytocin can have a variable effect on hemodynamic status months in patients with eclampsia. So in those situations, it's better to rapidly transport that person to the hospital because there could be some pretty significant consequences to the patient that are going to be very difficult to manage pre-hospital.
Excellent. So some tremendous benefit to those patients that meet that oxytocin condition indication there. Good. The next one we're going to go over is a tension pneumothorax, specifically for the ACPs. So they'll happily note that the mandatory patch point has been removed. What other changes have been made?
So the other big change is the location. So as has been previously reviewed at some educational sessions for advanced care paramedics, formally within the medical directive now is the consideration for the second intercostal space, the fourth intercostal space in the anterior axillary line. Literature has supported that space as a higher success rate and should be paramedics' first site for needle thoracostomy. And the old site at the second intercostal space in the mid-clavicular line, still an option and would be considered a secondary option depending on the clinical situation that the paramedic has dealt with. But very excited that that is now formally recognized within the standard as an acceptable site.
Good, so a higher success rate in that fourth intercostal space. Hopefully.
Absolutely.
Good. Next one is the combative patient. So formerly was auxiliary, is now moved to core for the addition of ketamine, but some slight changes to the midazolam dosage. Basically just allowing the paramedics to use their judgment on weight-based dosing. But any comments on the ketamine?
Yeah, so for our advanced care paramedics, this is going to be a big change. Ketamine has been available as an auxiliary medication for combative patients for a little while now within the province of Ontario. It's now moving to core, so it will be coming to the advanced care paramedic scope of practice within northwestern Ontario. Ketamine use is specific to excited delirium and severe violent psychosis. That is going to be all addressed in in-person sessions and online education for advanced care paramedics, but very specific subset of patient population that ketamine is useful for in combative patients. The other big change within the combative patient directive is around the reversible causes. So through paramedic feedback and I think some review of the literature around reversible causes in combative patients, that has now been removed from the medical directive, and that's really just from a paramedic safety perspective. If you're giving a medication to sedate a patient, whether it be ketamine or midazolam, probably realistically not safe to get a blood sugar before you do that, and not realistic. So this is just to be in line with what realistically happens in the world. Get that patient to a safe state where you can safely then look for reversible causes, as opposed to looking for reversible causes and then sedating them. Because while you're getting that blood sugar, you're probably going to lose a couple teeth or worse, and we don't want that to happen. So make the patient safe, utilize your medical directives, then start looking for your reversible causes. Most notably in that situation would be checking your blood sugar.
Yeah, more appropriate change for benefiting the patient as well. Like you said, patient safety for everybody involved there. Yeah. Next one we're looking at is the supraglottic airway. Quick minor change is that it doesn't necessarily need to be administered in strictly VSA patients. It could be in your pre-arrest patients, that being without a gag reflex. Nausea and vomiting, we've got a new addition of a medication, namely ondansetron.
Yeah, so ondansetron, again, a medication that's been around for a long time, used in hospitally and as an outpatient very successfully. Ondansetron has the benefits over dimenhydrinate in that it has a different mechanism of action, has a lot of utility in certain specific etiologies of nausea and vomiting. But again, another tool to the toolbox for paramedics to treat a really debilitating symptom in nausea and vomiting and give patients relief of their symptoms en route to the hospital. There are a couple specific contraindications, specifically prolonged QT, which again will be reviewed in great detail in the online education, but very excited to have this additional treatment option for nausea and vomiting available to our patients. And you can use dimenhydrinate about 30 minutes after you've used ondansetron if there's been no relief of their symptoms. So two-pronged approach sometimes is better than one.
Good, so we'll target some additional patients that will benefit from this new medication. Another slight change is the ACP CVAD use. So slight wording changes that it can only be accessible for external lumens only. What does that mean?
Yeah, so those are all of the non-implantable devices, and really the reason why we're focusing on external devices is a lot of the internal or implanted devices require specialized equipment. Some of them are changing quite regularly and do require some specific training. And most often than not, the services don't actually have the capable devices to access some of these implantable devices. So in a situation where there is an implantable device, unfortunately, paramedics are going to have to attempt to obtain a peripheral IV if certified for independent IV placement.
Great. So the last one we'll discuss is the procedural sedation. It does remain an auxiliary directive, but there is a new medication there, fentanyl.
Yeah, so again, specific to our advanced care paramedic practice in Northwestern Ontario, fentanyl is back as an auxiliary medication. At this point, to be determined if this is going to change treatment algorithms, but has been added to the procedural sedation medical directive as an auxiliary medication.
Great, yeah, and again, and lastly, a very slight dosage change for the midazolam approach for the procedural sedation. But other than that, thanks for the quick refresher and update for ALS-PCS 5.0, and we'll look forward to our next one.
Yeah, great. I hope everybody finds the changes to ALS 5.0 to be patient-centered and paramedic-centered. A lot of work has gone into these directives at the provincial level, and I'm really excited that they're finally coming to fruition, although a little bit delayed from the COVID pandemic, but happy to see them finally rolling out. And as always, any questions or concerns, feel free to contact us here at the base hospital office. And we will see you at in-person education.